Assalamu alaikum. Good evening, everybody, and welcome to the Summer School of Diabetes. There are 6 modules in this summer school for diabetes, and this is the 4th module. I would like to thank the sponsor for all the modules, Lily, generously sponsoring all the modules throughout this course. I would like to welcome and thanks the speaker for this event this evening. And I would like to welcome all the audience. And there's increasing number of audience as we go along. Now, just briefly, this summer course was organized by the Emirates Diabetes Endocrine Society with endorsement of the Emirates Family Medicine Society as well. It is focusing on early diagnosis, weight center care, oral therapy, injectable complication prevention of diabetes, and precision medicine. The aim of it is to unify across the whole country the treatment and the handling of diabetes. And after the recent publication of the Emirates Diabetes Society of the guidelines how to manage diabetes, we came up with this summer course to send the message across and to look in terms of unifications of the handling diabetes, whether it is in primary healthcare or secondary healthcare setting. So the module are focusing on the pathophysiology, diagnosis, classification, management of diabetes, the recent guideline published, and the looking at individualizing therapy for the patients, along with managing diabetes complication and prevention of these complications before it happens. Not to forget, the most important thing is lifestyle modifications, adherence to medication, and long-term outcome of treatments and the disease as it progresses over the years. Now, along with the presentation, always there is case-based discussion with evidence-based decision-making for every clinical scenario. This 6 weeks courses are CME accredited. It is under a process at the moment, but you're going to get your CME certificate by the end of it. Not to forget, there's a certificate of completion of the summer school on the condition that you're going to respond to the questions by the end of each module. So each module has pre-module questions and post-module questions that need to be responded to. We are now in the 4th module, which is focusing on oral therapy for type 2 diabetes. Over the coming 2 weeks, we're going to have injectable therapies and diabetes complication from risk to prevention. Your learning journey starts with the registration and enrollment in this course. Complete learning MCQs for each module. Complete 6 weeks of learning in the 6 modules. Join the live expert discussion panel. Complete post-learning MCQs for each module. And in the end, you're going to get your certification awarding after all completion of the modules. Simple as every CME activity, the webinar is live, and you could, if you're missing part of it or you want to go to the previous episodes, you could go to the website, YouTube of EDIS, and you could find your module and go through it. The webinar will be available on demand. Each session has a Q&A. Please submit your question. We're going to go through them and respond to them as well. CME certificate for each module is highly likely to be 2 CME hours, but yet to be confirmed. Your attendance for this course will be monitored, and that's what we're going to grant you the CME hours. Okay. Right, we're going to start our module right now, which is focusing on type 2 diabetes oral therapies. And we're going to start with our first speaker, Dr. Khadija Hafid. She's a consultant physician, diabetologist, fellow of the Royal College of Physicians of Edinburgh, clinical professor of medicine at Mohammed bin Rashid University. And the title of the talk will be on oral therapy, the past, present, and the future.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Professor Juma, for the kind introduction. And I'd like to also thank the organizers for inviting me to participate in the fourth module of the Diabetes Summer School. So as has already been mentioned, I will concentrate on or give a brief introduction on the oral hypoglycemic agents as we have them now. These are my disclosures. And what I'd like to do is really look at a historical overview on the evolution of the oral hypoglycemic agents. And then I'm going to look at the current paradigms in type 2 diabetes management. So that's the present. And then we'll take a sneak peek into the future. So just as a reminder, and probably this audience doesn't require any reminder, is the ominous octet first coined by Ralph DeFronzo during the seminal American Diabetes Association Banting lecture in 2004, where we know that type 2 diabetes is not a singular defect of the pancreas, but it is really a multi-system failure. And most of the pharmacotherapy that we now utilize is targeted at these multiple pathways and hopefully done simultaneously. So if we look at the progress over a century, we can see that we've really come a long way. Before insulin was introduced in the 1920s, the mainstay of treatment of diabetes used to be, believe it or not, starvation diets. You know, people were put on very low calorie diets. And then we moved on to the sort of 1920s with the discovery of insulin, and then came the first oral options in the 1950s. These were the first generation of sulfonylureas, then followed on by the sensitizers like metformin. And then, you know, moving on from the 1990s, we had the advent of SGLT2 inhibitors and the GLP-1 receptor agonist. And then we're going to look and see what the future has in store for us. So if we were to try and sort of split it up into eras of pharmacological evolution, we see that the first era was that of the age of discovery. That was and the initial focus was really on replacement of insulin, either through insulin, injections or the use of secretagogues such as the sulfonylureas. The second era was then on the insulin sensitizers, when things like metformin came into play, and then later on with the TZDs as well to address peripheral resistance. The third era came during the 2000s with the incretin revolutions, these gut hormones via the DPP-4 inhibitors and injectable GLP-1 receptor agonists together really revolutionized the way we manage diabetes. But I think the real breakthrough came a decade after that, when these agents showed that, some of these agents showed that they could actually protect the cardiovascular and renal systems. And this is kind of the evolution that we've had. But look at the curve that is here on the red, is that despite the many therapies that we've had over the last century, the global prevalence of diabetes continues to rise. So now in the guideline that Dr. Juma talked about earlier, that has been mentioned in the previous modules as well, we want to highlight that pharmacotherapy is just one of the pillars, and it is not the whole strategy about managing hypoglycemia. So pharmacotherapy is part of this carousel where we need to be able to emphasize on the physical activity and lifestyle intervention, medical nutrition therapy, weight management, which was discussed in module 3, sleep management, and smoking cessation as well. We need to be able to integrate this in a structured way in order that we may achieve and sustain not just optimal glycemic outcomes, but also improve on the cardiometabolic outcomes as well. So the evolution of type 2 diabetes management really has shifted from this glycemic control to a cardiorenal metabolic risk-based care. And the management is really from a glucocentric approach to one where we're managing risks and its outcomes-driven strategies. Pharmacotherapy, therefore, needs to be very individualized and selected not just for the glycemic efficacy, but also on the impact that these agents have on cardiovascular and renal outcomes, their hypoglycemic risk, the effects on weight, safety, and of course, cost considerations as well. Evidence from the cardiovascular outcome trials has already shown that certain drug classes provide benefits beyond glucose lowering, and you will hear more about that. The GLP-1 receptor agonists and SGLT2 inhibitors are one of the two classes that have shown both cardiovascular and kidney protection in addition to their glycemic benefits. So as cardiorenal complications, we know, are the major contributors to both morbidity and mortality in individuals with type 2 diabetes. Treatment decisions should prioritize the overall cardiometabolic risk reduction rather than just glycemic control alone. So let's look at the individual sort of therapies. And I start with metformin. You know, we've had metformin for over half a century now. And if we look at its glucose-lowering efficacy, we know that it's quite high. It has no risk for hypoglycemia, a potential but modest effect on the weight. There might be a potential for a reduction in the major adverse cardiovascular events. It doesn't have any effect on heart failure or on CKD progression, and it doesn't have any effect on metabolic-associated liver disease as well. And the SGLT2 inhibitors, on the other hand, have a moderate, low to moderate effect in terms of glucose lowering. There's no risk for hypoglycemia. They have an intermediate effect when it comes to the weight. Agents like canagliflozin and empagliflozin have definitely shown a benefit for MACE reduction, whereas it seems to be a class effect when it comes to heart failure. And then when we look at CKD reduction in CKD progression, we have canagliflozin, EMPA, and dapagliflozin as agents that have actually shown through the cardiovascular and renal outcome trials. We do not there is no known effect on metabolic-associated liver disease. The second generation sulfonylureas are very efficacious when it comes to glucose lowering. However, they do have a moderate risk for hypoglycemia. There is a tendency to weight gain. They do not have any effects on MACE, heart failure, or CKD progression, and there are known effects when it comes to metabolic-associated liver disease. I'm not going to talk about insulin and its analogs because this will be covered in the next module when we're talking about injectable therapies. The DPP-4 inhibitors have also been used quite widely. They have a modest efficacy when it comes to glucose lowering, but no risk for hypoglycemia. The effect on weight is neutral, and so is a reduction in MACE. Most of them are neutral when it comes to heart failure, except for saxagliptin, which had a potential in some individuals to increase the risk for heart failure. They're also neutral when it comes to CKD production and have unknown effects on metabolic-associated liver disease. The thiazolidinediones, the TZDs, have also a moderate risk in terms of glucose lowering, but no risk for hypoglycemia. There might be a tendency to weight gain. There might be a potential benefit in terms of MACE reduction. They may have an increased risk for heart failure and therefore have to be used cautiously and in people with ischemic heart disease. And they've not shown any sort of benefits when it comes to progression of chronic kidney disease. They, however, may have a potential benefit when it comes to metabolic-associated liver disease. Now, the sort of new kids on the block are the oral GLP-1 receptor agonists with a moderate to very high efficacy when it comes to low glucose lowering with no risk for hypoglycemia, intermediate to very high efficacy in terms of weight reduction. And then when we look at MACE, of course, we know agents such as liraglutide, dulaglutide, and semaglutide have shown definite benefits in terms of MACE reduction. Semaglutide in the higher dose of 2.4 in obesity-related HFpEF in type 2 diabetes. And we also have evidence of reduction in progression for chronic kidney disease and for metabolic-associated liver disease. So I'll concentrate, because we're talking about these oral agents, on the oral GLP-1 receptor agonists. And at the moment, we have semaglutide in oral formulation. This was made possible, of course, because it's a peptide. It was made possible in oral formulation by the addition of an absorption enhancer or a snack to increase the bioavailability and reduce the digestion from the digestive acids within the stomach. The addition of a spacer and a C18 fatty acid diacid chain provided strong binding to albumin. And when we give this agent, because it is a peptide, it has to be taken on an empty stomach. Individuals taking the drug have to wait for at least half an hour before they can take on any other medications or eat or drink. So, we usually recommend for most patients to take it in, very early morning, and then they have to wait until they can have their meal. The dose also has to be done in an escalation manner, where you start with 3, and then the maintenance dose is at 7 milligrams, and then you can intensify if required to 14 milligrams. The advantage is that it doesn't require any dose adjustment for elderly patients, anybody above the age of 65, or those with renal or hepatic impairment. The Pioneer program was the clinical program that focused on the efficacy and safety of oral semaglutide, and it was studied in a number of disease scenarios. Against the Pioneer 2 looked at the efficacy against SGLT2 inhibitors, against the GLP-1 receptor agonists, against the DPP-4 inhibitors, and Pioneer 6 was the cardiovascular outcome trial. So what we've known from this agent is that through the large safety database with more than 5,000 patients on the medication, the most common adverse event would be gastrointestinal. This can be done, of course, mitigated through slow titration, and making sure that patients are having smaller meals and avoiding sort of spicy, fatty foods. It is associated with a very low risk of severe hypoglycemia, and the overall safety profile in terms of retinopathy is not any different from that we've seen with the injectable GLP-1 receptor agonists. Now, the other one that's relatively new is the oral non-peptide GLP-1 receptor agonist, orforglipron, which can begin as a once daily oral administration with or without food, because it's a non-peptide. The maximum concentration is usually achieved within 4 to 8 hours after the dose is taken. And the bioavailability is around 77% after the 0.8 milligram dose. So here we now have an agent that can be taken as well once a day at any time without any food or water restrictions. The ACHIEVE clinical program is the efficacy and safety program for type 2 diabetes. These are phase 3 clinical series that have evaluated orforglipron in population of patients with type 2 diabetes. More than 6,000 patients were enrolled in this program, and it did show a significant reduction in hemoglobin A1C, together with, of course, the weight loss effect. So ACHIEVE-3 was a head-to-head trial that compared ORFO with oral semaglutide in patients taking metformin. And this was published in The Lancet quite recently, which demonstrated ORFO provided a statistically superior reduction in A1C levels and body weight. ACHIEVE-2 and 5 were trials that evaluated its efficacy against the SGLT2 inhibitor dapagliflozin. And again, it showed a superior efficacy in terms of glucose management and weight reduction against the comparator. ACHIEVE-1 and 4 were dedicated to evaluating the long-term cardiometabolic health and safety profiles across different diabetes stages. A recent publication in Diabetes in Primary Care just looked at the comparative effectiveness of orforglipron with semaglutide. And this is, of course, not a head-to-head trial, but just from the clinical trials, we can see that the A1C reduction and the mean weight reduction for orforglipron is higher compared to semaglutide. But the self-reported gastrointestinal adverse events and discontinuation due to adverse events were also higher in the orforglipron arm when compared to semaglutide. Again, I caution that this was not a head-to-head sort of trial. Now, coming back to the strategies that we can use for management of type 2 diabetes, drugs in combination that act on the multiple pathophysiological defects is one strategy. Treatment targeting the pathogenic abnormalities and not simply reducing the A1C, and more will be discussed by the coming speakers. And early treatment intensification in order to prevent or slow down beta cell dysfunction is extremely important. So what we want to do is this early combination, and Dr. Milad is going to talk more about this. So we are looking at agents that can synergistically act together to result in more durable treatment effects without increasing the risk of adverse events, and also to reduce the risk for clinical inertia. And we know that reducing clinical inertia is really important because it usually comes with a high cost. If we exercise clinical inertia, then we know we have higher risks for heart failure, myocardial infarction, and stroke, as was shown in the UKPDS study. Now, when we're looking at the comprehensive diabetes continuum, as I've mentioned earlier, the paradigm shift has really been towards focusing on this personalized, risk-based strategy, where, of course, glycemic homeostasis is important, but cardiorenal and metabolic health has to take precedence. Psychological well-being, reducing the diabetes stress and cognitive decline, and then hepatic health has also been has to be incorporated in the management strategy. So the decision cycle for a person-centered glycemic management really depends or really pivots around reducing the complications and optimizing the quality of life. This, of course, has to be done on an individualized basis, looking at the specific context that the patient has, their risks and preferences, incorporating education at all levels, and using shared decision-making in order to have a plan which is adoptable by the patients. So in trying to reduce these diabetes complications, of course, we have these 4 pillars that look at both glycemic management, blood pressure management, lipid management, cardiorenal protection, and weight management as well, on a foundation, of course, of diabetes education and lifestyle modification. What are the things that we want to consider when it comes to the A1C goals? Of course, you would want to favor a more stringent goal. When you have somebody who has good health function with low treatment risks and burdens, you would even want to go to as low as 6.5%, and this would include most of the adults that we see in clinical practice. Conditions that would favor a less stringent goal would be those who have high risk for hypoglycemia, a high treatment risk and burden, if they've got sort of established cardiovascular complications or very severe and life-limiting comorbidities, then, we may be able to relax those goals to about, less than 8%. And of course, for older adults with very poor health and complex conditions, and we may not even have an A1C goal for them. So the sort of clinical arsenal that we have in terms of the oral agents are the biguanides, metformin, we have the second generation sulfonylureas, we have the TZDs, mainly in pioglitazone, DPP-4 inhibitors, the SGLT2 inhibitors, and the oral GLP-1 receptor agonists. And I've already talked about the glycemic efficacy, the hypoglycemia risk, weight change, cardiovascular effects, the renal effects, and of course, just to add on the last column, is the cost of these agents, which can be sometimes something that needs to be considered when you're taking that decision with the patient. Now, based on this evolution of the medications that we've had, our guidelines have also changed quite significantly. So you can see before 2020, the main focus was really on just sort of glycemic control. But with the advent of the cardiovascular outcome trials, with the SGLT2 inhibitors and the GLP-1 receptor agonists, inclusion of these agents was advocated independent of the glycemic control. And then as we move forward and trying to look at this sort of holistic approach to the management of type 2 diabetes, bearing in mind that it is associated with a lot of cardiorenal burden, we know that now we advocate for the use of these agents independent of the use of metformin as well. So then to summarize the sort of paradigm shift staircase that we've had over the decades is, before the 1920s, the main objective was really survival. We needed to keep these patients alive. Starvation diets were actually the norm at the time. It was extreme carbohydrate restriction before the discovery of insulin. And then between the 1950s and the 1990s, the concentration was really about glycemic control, lower A1C to prevent microvascular complications. And the agents that we had at that time were mainly metformin and the sulfonylureas. And then from 2008, we've been thinking mainly around organ protection. So now we need to prevent macrovascular mortality. So it's the heart and the kidneys. And with those agents, we have cardiorenal protective agents in the SGLT2 inhibitors and the GLP-1 receptor agonists. But what does the future hold? Well, looking at emerging therapies, once weekly or even monthly orals, as we advanced in terms of the formulation technology, so we can have more gastrointestinal permeation enhancers that are aimed to make other peptide-based drugs like the novel GLP-1 receptor agonists and perhaps oral basal insulin universally available in the pill form. Of course, there's smart insulins and glucose responsive systems, and these will be talked about probably as emerging therapies when we talk about injectional therapies. Regenerative beta cell therapies as well, maybe something that we might be seeing in the future. And of course, we talk about precision diabetes, being able to customize the medication choices based on the patient's specific genetic, metabolic, and possibly their autoimmune markers as well. And with that, I'd like to thank you all for your attention, and I will hand it back over to our chair.
Thank you so much, Dr. Khadija. Wonderful talk. We're going to take the questions by the end of the module. So please write down your questions, and we're going to respond to them. We are moving to the second speaker now, and is Dr. Mohammed Milad, consultant endocrinologist at Sheikh Tahnoun Medical Center in Al Ain, and he's the chair of the Department of Internal Medicine at Tawam Hospital. clinical professor at UAE University. And the title of the talk is Early Combination and Durable Control. Welcome.
Thank you very much, Professor Jama, for the kind invitation and for the kind introduction. Let me just share my screen. Okay. Can you see my screen?
Yes, yep. Okay. Yep, now
Okay.
clear, yes.
All right, thank you very much. So colleagues, over the coming 25 minutes, I'll try and cover early combination and durable control in newly diagnosed diabetes. These are our learning objectives for tonight. So I'll review the evidence supporting the use of early combination therapy in type 2 diabetes mellitus, help you to identify patients in whom early combination therapy is more appropriate than sequential escalation. Then we'll try and see how we can choose the right combination that improve durability while limiting hypoglycemia and weight gain, as we heard from Dr. Khadija, and try to see how can we interpret short-term HbA1c responses that we can get with some groups of medications and within the context of long-term treatment durability. And at the end, we'll come up with a 3-month escalation plan that help us to initiate therapy and maintain it and help to escalate treatment. So let's start with 2 case scenarios. I think you would agree with me that these are typical cases. One of them is lagging behind because of lack of decision making. So 52 years old, newly diagnosed with HbA1c of 8.7, no atherosclerotic cardiovascular disease, but he's obese with BMI of 33, started on metformin and lifestyle. As you would think that the guidelines used to tell us to do. At month 3, his HbA1c dropped down to 7.5, and he did manage to lose 3 kilograms, which is roughly what you would expect with lifestyle changes and some help from metformin, and he was not reporting any hypoglycemia. So the doctor's decision was hoping for the best, and he told the patient to continue and recheck his HbA1c and the rest of bloods in 6 months' time. So clearly this patient is lagging behind. When we compare him to the second case, which is a 58 years old patient presented with rather high HbA1c, established atherosclerotic cardiovascular disease at diagnosis, he was started on triple therapy, including disease-modifying agents, both SGLT2 inhibitor and semaglutide. And at month 3, he did drop his HbA1c quite impressively. And you would expect that looking at the combination, and he was reporting no tolerability issues. So you would say, but how could that happen? Clearly, the escalation plan was agreed with the patient and the dose of medication was increased gradually. So the decision quite appropriately at this stage is to continue and recheck his HbA1c appropriately at 3 months. So we've seen this from Dr. Khadija, and it is very important to keep in mind that always these are data by extrapolation. Any drop in HbA1c, regardless where you're starting, gives you significant benefits, whether you're talking about microvascular complications, any diabetes-related endpoints, diabetes-related deaths, or myocardial infarction. And this is from UK BDS trial outcome that was reported in 2000 by Stratton and his colleagues. So it is very important to try and achieve HbA1c reduction and achieve it early. That's why durability is very important. So we heard about clinical inertia, and this has been confirmed by Kamlesh Conti and his colleagues in a very large study that enrolled, looked at the data of more than 80,000 people from the data from GBs in UK. And what you're looking at here are 3 different graphs, A, B, and C, that looks at patients who were either started on single, dual, or triple medications, and they're stratified by their baseline HbA1c. And as you can see here, if patients were at a lower HbA1c, they are actually spending quite a lot of time, on average between 5 to 8 years before any intensification of therapy is made. And this is what is defined as clinical inertia, and that is definitely hurting patients. And if this hurts patients because time means lack of glycemic control. So waiting for monotherapy to fail is actually, before escalation, is causing harm to patients. And on average, if you look at patients who were enrolled in this study, patients who were on single agents, they spent on average 2.9 years before any escalation was made. And for patients who were on 2 agents, they spent more than 7.2 years before any escalation. Just hear these numbers. These numbers are really scary. And for almost a third of patients, no escalation for more than 6 months. And this tallies with majority of what happens in clinical practice. So let's review the evidence that supports the use of combination therapy. So what you can see here is evidence in table form from 4 well-randomized, well-designed randomized controlled trial. One of them is the Verify that was conducted by David Matthews and his colleagues and reported in 2019 and enrolled more than 2,000 patients. And this enrolled patients with quite low HbA1c at early diagnosis, and they use a combination of metformin and vildagliptin. And the median, the primary endpoint was the durability outcome, and the median time to failure was reduced by 49%. And there was no events of hypoglycemia that were reported in both subgroups, and quite clearly because of the choice of medications. In the EDIC trial that was conducted by Abdul Ghani and his colleagues, they enrolled 249 patients with a mean HbA1c of 8.6 and more than 5 months since the diagnosis of type 2 diabetes. And they use a combination triple medications, including exenatide and 2 oral medications. And they managed again to reduce the significant 7-fold risk reduction of events of hypoglycemia in patients on triple therapy, and significant weight loss in patients who were taking the triple combination, as well as significant reduction in HbA1c at 2 years with durability compared to patients who were on the escalation regimen. In the initial triple medication, they used they used metformin, sitagliptin, and lobeglitazone, and they enrolled patients with HbA1c between 9 to 12% who are drug naive. And again, they managed to achieve a target HbA1c in almost 70% of patients compared to 52% of patients at 12 months, and there were lower risk of hypoglycemia in the treatment arm compared to the sequential escalation arm. One of the other trials, which is well designed, that enrolled 104 patients, is the triple axle that used a combination of metformin, dapagliflozin, and saxagliptin, and enrolled patients with 9.3% at new diagnosis of diabetes, and they managed to achieve HbA1c of less than 6.5% in 46.3% in both groups. But the main difference between the two groups is the risk of hypoglycemia and the weight gain that happened more in patients on sequential therapy. There has been meta-analysis that looked at the benefit of combination therapy, and the 3 of them enrolled quite significant number of patients. And the most recent one was conducted by Naeem Issa and his colleagues and reported in February 2026, and included 11 studies with just under 24,500 patients, and they looked at time to failure, and this was reduced by 49%, and there was 7.4-fold reduction in the risk of hypoglycemia in the early combination therapy, and there was 5.3 kilogram difference favoring combination therapy. And this was repeated as well in the other two meta-analyses, although the inclusion criteria was different and the medications that were used different, and the combination that used for sequential therapy was different. Early combination does have other benefits, non-glycemic benefits, and we heard from Dr. Khadija that we now we treating patient in non-glycemic centric way, and the EDIC trial looked at some group of their patients, and they looked at the change in the carotid intima media thickness, comparing both the early combination versus the conventional therapy. And as you can see here, there was significant change favoring early combination therapy. They also looked in the same trial, in the EDIC trial, they looked at the change in the hepatic steatosis using FibroScan and grading patients S2 to and S3, and they looked at patients who reach a fibrosis stage of F3 and F4, and again triple combination use early when here whether you looked at hepatic steatosis, hepatic fibrosis, or hepatic steatosis S2, S3, or hepatic fibrosis F3 and F4. So I just want you to spend a few seconds looking at the graph, the bar charts in D, the significant difference and the significant reduction in the risk of progression into fibrotic changes in the liver. Also, triple axle, they looked at the non-glycemic evidence, and they looked at in patients who were randomized, they had reached target without harm more often when the initial therapy, triple combination, and they had less hypoglycemia, weight gain, and dropout combination in the initial triple therapy compared to the sequential stepwise add-on. So combination therapy initially wins both in terms of achieving glycemic targets, but also non-glycemic factors as well. So how can we identify patients whom early combination therapy is more appropriate than sequential therapy? So identifying, firstly, we need to identify patients who early combination is not appropriate because patients with severe catabolic status and severe hyperglycemia will need to be started initially on insulin, probably in combination of GLP-1 receptor agonist-based therapy, at least in the first 3 to 6 months to improve the catabolic status and treat the hypoglycemia before moving to oral combination therapy. We need to use early dual therapy when a single agent is unlikely to get to the goal. And the commonly used practical threshold that has been advocated by all guidelines is if HbA1c is above or equal to 1.5% above the patient individual target. So if your patient presents with HbA1c of 8.2 and their individual target, they're young without any complications or risk of atherosclerotic cardiovascular disease, their HbA1c target should be less than 6.5. So clearly, a single agent is not going to get them down to their target. So in that situation, you will need to use a dual oral combination therapy at onset. You need to identify patients who should be treated with initial combination regardless of anything. And these are the typical patients with established atherosclerotic cardiovascular disease, patients with high atherosclerotic cardiovascular risk, patients with heart failure or CKD with eGFR less than 30, or albuminuria, patients with overweight and obesity, or where weight loss is a priority for them. For example, patients who are at risk of obstructive sleep apnea and at risk of steatosis, liver steatosis due to weight gain. You also need to consider avoiding hypoglycemia for certain patients, or weight gain, or regimen complexity for elderly. Then dual combination from the start, maybe in single pill formulation, is more appropriate than a single formulation. You need to choose wisely, because verified subgroup analysis seems to indicate that younger patients at diagnosis seems to gain more benefit, and this is shown by this in this bar charts. So there is less risk of failure of metformin alone compared to using combination therapy in younger age group compared to late onset. So how can we choose right combination? This has been touched on by my colleague, Dr. Khadija, but I'm just gonna go through this quickly. So it suffices to say that ADA guidelines now clearly indicates that patients should be treated with consider combination therapy at initial therapy to shorten time to target. Treatment modification for ulcers not meeting individual goals should not be delayed. And all of these are graded as A, grade A. So if we look specifically at certain groups, as I've mentioned, the guidelines now specifically mention specific groups, as I've already indicated. I'm not gonna spend much time here, but it suffices to say that you need to clearly identify the subgroup that your patient belongs to choose the right medication. While NICE 2026 has clearly now stipulates that all patients should be treated with a combination of metformin and SGLT2 therapy. I'm just going to go through this regardless of what presentation they present with, unless they are intolerant to either combination. So NICE guidelines went further ahead more than any other guidelines by stipulating that dual therapy is a must for every single patient. What about ACE guidelines? ACE guidelines now stipulates that very similar to ADA. So if there are associated conditions, then it asks you for use of a combination therapy. But if you are treating patients in a glycemic centric control algorithm, then it tells you that you should not delay escalation therapy, and you should consider starting with 2 agents if HbA1c more than 1.5% of above the individual target. I'm just gonna skip through this very quickly because this is fairly repeating what Dr. Khadija have said already. EDS released consensus statement in 2026, and it falls short. It does support combination therapy for groups. Sorry, I'll just go back for the groups in tier 4, tier 3, and tier 2, but in the low-risk medications, a low-risk group with no cardiovascular risk factors, it does still recommends using single agent at the start, but it tells you to test after 3 months and escalate treatment and avoid clinical inertia. GRADE have shown us without any doubt that the choice of second agent changes the composite risk twofolds. Then the composite being is combined confirmed HbA1c less than 7.5, at least 5% weight gain, and severe recurrent hypoglycemia. And this has been reported to be highest with glimepiride, the second generation SUs. So the choice of medication matters significantly, and we have adequate evidence to support that. This is fairly repeating what Dr. Khadija have told us, so I'm not going to spend a lot of time, but just keep this for you to glance for a few seconds, just telling you what combination therapies that are currently recommended by the guidelines. In 2018, Elkost and her colleagues came up with this subtyping of type 2 diabetes. So maybe phenotyping and subtyping of type 2 diabetes is more important or as equally as important than HbA1c. So clearly for said severe autoimmune diabetes, oral medications would not work, and severe insulin deficient said is probably going to progress to requiring insulin very quickly, but GLP-1 receptor agonist therapy are probably required and can benefit patients at least in the early stages. MARD, on the other end of the spectrum, requires very little treatment, and this is probably where a situation where you can use more milder forms of combination therapy. So how can we interpret and how should we interpret short-term HbA1c responses within the context of long-term treatment durability? Because as you can see, glyburide or SUs can give you significant early response. But the problem with that has been shown from ADOPT that the fastest starters, medications that gives you the best response early, are not actually the most durable agents, and actually they don't maintain HbA1c on the long run. As you can see here, the 5-year cumulative monotherapy failure was highest with glyburide, and the months maintained with HbA1c less than 7% were highest with rosiglitazone followed by metformin therapy. So you need to look at the HbA1c within the context of the agent that you're using, and you need to rank the response based on that. So baseline HbA1c as effect modifier, the durability advantage of early combination therapy appears most pronounced in specific HbA1c ranges. The studies of patients with mild hyperglycemia, as I've shown you in the first table, such as Verify, showed dramatic response differences in time to treatment failure, 36% versus to 61%. Cohort studies by Vendaya demonstrated stronger benefit in patients with HbA1c more than 9 compared to lower HbA1c. Triple Axis showed quite elegantly that enrolling patients with higher baseline HbA1c, because its mean was 9.3%, found no difference in HbA1c changes. Remember, there was no difference in HbA1c achievement, but the main outcome difference was in the rate of hypoglycemia and the weight gain. So bottom line, evidence suggests that early combination may prevent treatment failure more effectively than producing greater absolute HbA1c reduction when baseline control is severely impaired. So just ponder about this statement. So we are using, what I'm trying to say is that we are advocating the use of early combination, not merely for the glycemic control, because you can achieve glycemic control by using SUs, for example. We are advocating its use to maintain durability. So that's the most important thing. So how can we build a 3-month escalation plan to achieve it? Very important that a 3-month escalation plan only work. Remember, it only works if the trigger for escalation was decided in advance, not improvised at the follow-up visit. So you need to document it, you need to agree with your patients, and you need to say what will trigger the escalation. You need to document it to remind yourself, and also your patient could be seen or might be seen by somebody else. So it needs to be documented, clearly explained to the patient that in 3 months' time we'll increase or add something else if we did not achieve that. Agree the target and review date before you start. Set an individual HbA1c target with the patient at initiation, not a generic population target. And this has been shown elegantly by Dr. Khadija in her last slide. And you need to decide in advance what will trigger escalation. Is it target not met? Is it inadequate rate of fall, or is it tolerability problems? And you need to fix a review no later than 3 months. It could be earlier than 3 months in some category of patients, but definitely not later than 3 months. Definitely not 6 months. Not whenever the next appointment happens to fall. This is old medicine that we should not practice anymore. So having said that, we are still thin on evidence. I didn't show you evidence to support the use of early combination to reduce cardiovascular outcomes or improve CKD or CRM endpoints, because we don't have that evidence. So what we don't have, we still have open questions, and these are questions that could generate very well designed trial. Is the timing of the drug matters? EDEC compared different agents as well as different timing. No trial has yet compared the same drugs started together versus sequential. So they compare different drugs, not the same drugs. So we cannot say that the same drug used sequentially is different from the same drug used in combination. Does the benefit hold at high baseline? I've told you that already. We don't have evidence for that because triple axel showed us that there is no difference in HbA1c attainment in both groups. There was only difference in glycemic depth. Does it reduce cardiovascular outcomes? I've already told you that there is no evidence for that, although there is a meta-analysis that showed us that there is no evidence, no significant difference in myocardial infarction, and this needs well-designed randomized controlled trials. How solid is the pool of estimate? Several trials contributed multiple publications, and meta-analysis included separate risk inflating factors. So we don't have very strong evidence base yet. Is sequential escalation actually inferior? There is no evidence to prompt that. Well-titrated sequential treatment done in time has not been proven to be inferior, provided the targets are genuinely reached in time. So if you avoid clinical inertia, you can still achieve the same target. What we are talking about here is avoiding clinical inertia. In practice, they often are not. So, Mr. Chairman and my colleagues, my take-home message is we need to avoid clinical inertia because it remains a major problem, and major international clinical guidelines and EDS now recommend starting early combination therapy for most of type 2 diabetic patients at diagnosis. We need to begin combination therapy at diagnosis when HbA1c is meaningfully above target, individual target, and this is graded as A evidence. Early combination therapy support disease modification rather than symptomatic control, and we have evidence, although very small sub-analysis from the EDECT as well as the triple axel trials. Early combination therapy is the only correct therapy options for certain patients' phenotypes, which I've already indicated to you. And we need to consider comorbidity when choosing the combination irrespective of HbA1c. We should forget talking about HbA1c. Now we're treating to reduce the impact of diabetes on organs until we have the tools to try and reverse diabetes. Thank you very much, Mr. Chairman, and I'm here to answer questions later. Thank you.
Thank you so much, Dr. Milad. Excellent talk, clear and concise, to the point. Thank you so much. And as mentioned, we'll take Q&As by the end of the module. We're moving to the third speaker now. Our third speaker is Dr. Mohammed Hassanein, consultant of endocrinology, professor of medicine at Mohammed bin Rashid University, and chair of Diabetes and Ramadan Foundation. The title of the talk is Oral Therapy Algorithms, Cardiometabolic Protection. The floor is yours.
Thank you very much, Professor Juma, for this kind introduction. So I hope you can all see my screen.
Yes, yes, enlarged now.
Yes.
Ready to go.
Okay, so we heard two beautiful lectures about oral therapy, whether in combination or not, the rationale for each of them, the pros and cons of each class, and so forth. Now, I will try to simplify this in a clear, maybe clinical practice presentation. The three documents I will be basing my presentation on is our latest Emirates Diabetes and Endocrine Society type 2 diabetes guidelines. It's recently published. The earlier cardiometabolic guidelines, that is a cornerstone for a big section of this methodology and attitude, and also the latest ADA standards of care. So I think you've seen the slides with Dr. Khadija. When we talk about cardiovascular disease, we often focus on one or the other points. We don't want glucocentric, but actually glucocentric, not centric, but glucose management is one of the four pillars, equal to the cardiovascular benefit of certain drugs, equal to the blood pressure management and the lipids management for cardiac protection. But obviously, for a person with type 2 diabetes, we also need to think of the weight, the smoking, the lifestyle, and diabetes education. And I'm going to base my presentation around clinical scenarios. Maybe we'll use a couple, and if we have time, I go for the third one. So we here have Ahmed, who is 56 years of age, and he works as a teacher. He has moved to the UAE 2 months ago, and this is his first consultation with you. He is also hypertensive 8 years ago, and type 2 diabetes was diagnosed 4 years ago. His current HbA1c is 7, was 6.4 before he traveled. His current medication is metformin 1 gram a day and amlodipine 5 milligrams a day. And if I'm in clinic, I would like to ask myself, how can I make a decision? You've just heard extensive guidelines from our guidelines, ADA, NICE, the ACE guidelines. How can I come to the decision? Systematic approach is the key. Detailed history, examination, and appropriate investigations. If we just can make a decision with this simple information, then we don't need doctors. Then simply we pass the information from the lab to the pharmacy and a prescription is generated. But we do need doctors, definitely, and not AI, because we need to go to the sophistication of the examination, the detailed history, and then whatever necessary investigations. So the cardiometabolic guidelines told us we have to screen the person, whether they are for example, here we're talking about type 2 diabetes. How we do this? Take full history, look into the symptoms of cardiac problems or claudication, smoking status. Examine their heart, chest, lung, abdomen, peripheral pulses. Examine their eyes for retinal fundal examination. Do ABI, and that's not a difficult test to do. And then order some essential investigation once a year, certainly at first consultation and annual review. An ECG, a proBNP, a renal function profile with serum creatinine, eGFR, and urine albumin creatinine ratio. A full lipid profile, a CBC and HbA1c are essential. Obviously, some other investigations are also important. Now, if you do all of that, if you take the right history from the person, and if you do the right examination and do these investigations, you will be able to come with a diagnosis. Now, as I mentioned, we do this on an annual basis. So who would be screened positive is a person who have abnormal examination, such as the peripheral pulse, for example, or retinal examination, or maybe you've heard on the heart signs or the lung signs of heart failure, or a carotid bruit, or something like this, or someone with abnormal investigation, such as an ECG, a proBNP, or renal function. So what happened to this person that, let's say Ahmed, our case scenario, he comes to you with simple situation, I'm here and I want a follow-up. But after doing these investigations, if Ahmed have any of these, then Ahmed is considered as screen positive. Now, I just assume that the screen positive is maybe albuminuria or impaired renal function. Then you refer to the right specialist, address all the measures, including specifically the lifestyle, and start the treatment as a very high-risk individual. Now, if the person is screen negative, and many will be screen negative, then start looking into 4 parameters: age, above 40 or below 40, duration of diabetes over 10 years or less than 10 years, and then the last 2 is the number of risk factors, cardiovascular disease risk factor. No would score 0, 1 would score 1, of course, and multiple score risk factors would score 2. And accordingly, perhaps a person without end organ damage will still score 4, and then they become very high risk. So this simple process would help you to go through our guidelines, which is based on the best knowledge of our regional patients, as well as the evidence that best suits our community. So we're going to focus on the oral therapy. Let's assume that your patient does not like to have an injection, or it is too expensive for them. So what oral therapy can you choose? And we'll do that with the case scenario. So going again to the case. And when you took history and when you examined Ahmed and when you did the right examination, you now find that actually Ahmed has a blood pressure of 139/84. His LDL is 110. His renal function is normal. His BMI is 31. He's a shisha smoker once or twice a week, and his ECG shows left ventricular hypertrophy. So if I were to ask myself the question, what is the cardiorenal or the cardiovascular or the cardiorenal metabolic risk of Ahmed, whether he's low risk, moderate risk, high risk, or very high risk, I go again to and then the second question is, after finishing with the levels of CRM, I need to define the current glycemic level and targets, as well as the other cardiovascular risk factors, including the blood pressure, the lipids, the smoking, weight, and maybe sedentary lifestyle and other stuff as well. Again, I remind you, cardiometabolic risk reduction is related equally to these 4 parameters on top of lifestyle and education. So if I were to go to the case, I have a person here who's in his 50s. So already he's above the age of 40, that scores 1. He have cardiovascular risk factors. But before going this, he already on examination have left ventricular hypertrophy. Without going to any of these, he has an end organ damage with the LVH that he has. So I will automatically be, even before thinking of all of this, say Ahmed is a very high risk person. But it's important to identify the other problems because they are targets for your management. You need to address all of them. As we just mentioned, the level of CRM, we decided here is very high risk. You need to ask yourself, what HbA1c you want for this person? His HbA1c now is 7. What would you like it to be? And then thinking of his blood pressure, his LDL, his smoking, his weight, all of these are points that will dictate your management for Ahmed. So again, similar to what I said, this is from our latest guidelines. He does have positive screen based on the ECG, and considering he is very high risk. So here I would switch him or add to him a GLP-1 or a GLP-GIP or an SGL2 inhibitor with evidence of benefit. Now we're talking about oral therapy. So I have here either the SGLT2 inhibitors or oral semaglutide. Orforglipirone, studies on cardiovascular protection results are still awaited. Now, if the person's primary problem is heart failure or renal impairment, then SGLT2 inhibitors are preferred. You might consider combining both. In some people's opinion, that would be good. In others, maybe we wait to see the impact of the first agent that you will do. And then if the HbA1c is still above target, then you add the other therapy of proven benefit. Now, if still the HbA1c is above target, you consider pioglitazone or metformin. Pioglitazone has evidence from one study. Metformin has evidence from the UKPDS. Still, HbA1c is above target, then you consider any of the other glycemic agents, take into account the efficacy of the drug, the risk of hypo, the impact on weight, and the cost. And finally, you would add or intensify insulin if he's not already on insulin. And don't forget, throughout the algorithm, we are talking about lifestyle intervention. Key for Ahmed is the weight and the smoking specifically. And as Dr. Milad mentioned, it's not just about giving 2 drugs or 1 drug. It's about we acting promptly and providing the person with the necessary education so that they would understand and adhere to the management plan. So as you can see here, a simple case that came to your clinic with an HbA1c of 7 on metformin only, after thorough history and thorough examination and an ECG, turns out to be a person that needs intensive treatment of all aspects. So here, I will prescribe him an SGLT2 inhibitor or an oral GLP-1 receptor agonist because we are talking about oral therapy. Now, if I'm talking in general, I might consider an injectable GLP-1 with evidence. I would try to improve his blood pressure by adding an ACE or an angiotensin II antagonist. I will start him on a high-intensity statin. I refer him for a smoking cessation clinic. I will consider and encourage him for an aspirin treatment unless there is a contraindication. So see, the challenge for all of us is this person came to you and perhaps he thinks that he's well controlled and he has no major issues. Now, obviously, if he did the ECG 6 months ago or a year ago, probably the signs of left ventricular hypertrophy would have been there. And being with all the other cardiovascular risks, the hypertension and the dyslipidemia and the smoking, he would have been classified as a higher risk person anyhow and would have warranted much of this treatment that we have prescribed him today. Now let's move to Ahmed, but slightly modified scenario. So again, the same job, same age, same name as well. And he also comes to you. He has type 2 diabetes, but he doesn't have hypertension. Okay? And I'm going to simplify it to you now by giving you all the necessary information. His HbA1c now is 7.7, was 7.4. His blood pressure is 129/74. His LDL is 110, and his EGFR is 88 with the ACR is normal. His BMI is 28. You did examine him and his examination was normal, and you did an ECG, it was all normal. You did examine his feet as well as recommended, and everything there was normal, as well as his retinal screen. And he's currently on metformin. So again, we need to have a systematic approach. What should we do and how can we choose the appropriate treatment for Ahmed, who is only type 2 diabetic with good blood pressure, with normal renal function, with a BMI of overweight, with normal cardiovascular, renal, and foot and retinal examination, being on metformin 1 gram daily, and he's adherent to his treatment. So thinking of his, again, the structured approach, the level of cardiorenal metabolic risk for him, low, moderate, high, or very high. And again, we go through the systematic approach and we think of the second parameter here, which is the glycemic level for Ahmed, and think of the other aspects, the blood pressure, the lipids, the smoking, and the weight. So thinking of the glycemic targets, you have seen the slide with Dr. Khadija. Glycemic targets for many people is less than 7. But if I'm fit and healthy and I'm not frail and elderly, then you would like maybe my HbA1c to be less than 6.5. And it's very important that you decide the target of HbA1c of the person, because that will be dictated by your choice of therapy. Now, obviously, if the person is older but still healthy, you might consider less than 7.5. But once we go into a bit of complex health issues or a bit of frailty, then we certainly relax a bit the glycemic control level. So thinking here of the case again, let's first quantify for the cardiometabolic risk. His age is above 40, so that scores 1. He's normotensive. His LDL is high for his condition. He's got normal renal function. He's not obese. His BMI is overweight. Cardiac, foot, retinal, and renal are normal. So he scores 2 points based on the age. His duration of diabetes is only 4 years. So 1 point here and 1 point here, then he scores 2 points. So to me, he's moderate risk person. But he also has we need to improve his glycemic control, we need to improve his LDL, and ideally we need to improve his weight, even though he is not obese, but we don't want to wait until he becomes obese. So here, I very much want to focus on 2 of the parameters, the glycemic management and the lipid, and the third one, which indirectly is related to the cardiovascular risk, which is the weight as well. So I need to think of the power, of the efficacy of the drugs that I choose. Now, this is exactly what we recommend in our guidelines. So in people with low or moderate risk category, of course, we need to think of the efficacy, of the risk of hypos, on the impact on weight and cost. So weight reduction here, you have 3 different levels of weight improvements. Moderate efficacy is SGLT2 inhibitors and the other GLP-1s, excluding tirzepatide and semaglutide subcutaneous, because these are the highest. Then following is dulaglutide, liraglutide, and oral semaglutide. And finally, others, GLP-1s and SGLT2s. Thinking of the efficacy of the glycemic control, again, we have very high levels of efficacy of tirzepatide, semaglutide, insulin, and combination therapy. Or high efficacy only, lira, dulaglutide, lixexenatide, oral semaglutide, metformin, TZDs, and sulfonylurea. And moderate efficacy is DP4 inhibitors and SGLT2 receptor agonist. And of course, a reminder here, don't use a DP4 inhibitor in someone on a GLP-1. So thinking again of Ahmed, HbA1c of 7.7, where do you want his HbA1c to be? Under 7 or under 6.5? His BMI is overweight, 29. So I need to think of something. And as the lecture of today is about oral therapy, then I would be thinking the reminder is choose a glycemic agent from the guidelines. Target blood pressure is below 130/80, which is achieved. Target LDL is below 100, and we need here to use a moderate intensity statin, and antiplatelets are not indicated. And more or less the same for the low risk, except that the LDL is below 120 here. So I would recommend here for Ahmed is to think of the lifestyle measures, because that's the root of the problem. I would choose any agent with weight benefit. So perhaps the metformin 1 gram a day, I will then give him a combination of metformin with SGL2 twice daily, or perhaps I would add an oral GLP-1. He doesn't have cardiac problems, so it could be either of the 2 oral GLP-1s that are available for us nowadays, and I will start him on a moderate intensity statin. So it's very clear to me that we need to have this systematic approach. And trust me, dear friends, if you do that once a year and document it, then you will be able to know the ins and outs of your the social history of your patient, the end organ damage, the investigations that will guide you towards what to do. And of course, don't forget, essential to examine your patient, because many problems are sometimes not detectable by the naked eye. They need a bit of examination. I would like to stop here with the photos of my beloved city, Alexandria, from where I am now, and I'm happy to take the questions at the end of the presentation. And I think I'm just on time. Thank you.
Thank you so much. Wonderful talk, Dr. Mohammed Hassanein. Wonderful photos. We'll not take any question about the photos, but we will coming any other questions. And we have been having excellent number of audience and sustainable throughout the module. Please write your question. We want to respond to them. Our last talk, but not the least in terms of important and speaker, our speaker, Dr. Alauddin Bashir. He's a consultant endocrinologist in Dubai Hospital, clinical professor of endocrinology at MBRU. And the title of the talk is focusing on type 2 DM in special population, highlighting, most importantly, the renal metabolic guidelines. Welcome, Dr.
Assalamu alaikum wa rahmatullah. Thank you very much, Mr. Chairman, for the kind introduction. I'd like to thank the EDS for the invitation to be part of this diabetes summer school. And my talk is basically about the UAE guidelines for management of diabetic kidney disease. And my talk is basically based on 2 recent papers that were published in 2026. The first one has handled the recommendations for screening, risk stratification, and targeted treatment for early diabetic kidney disease. And when we say early, we mean stage 1 to stage 4 diabetic kidney disease. And the second paper was published around 3 weeks ago about managing advanced diabetic kidney disease in UAE, which included management of patients of diabetes in patients who undergone dialysis and renal transplant patients, as well as management of hemodialysis, of diabetic ketoacidosis in hemodialysis patients. So these are the main papers on which I'm going to focus today. And just to start to pave the line for my talk, the diabetic kidney disease is known to be a driver of kidney failure in United Arab Emirates. Around 57% of the dialysis population in Dubai Hospital hemodialysis unit had diabetes as a cause of end-stage kidney disease. If we look at the Gulf region, diabetes among hemodialysis patients across the GCC is found in 74% in Kuwait, around 72% in Bahrain, Qatar and UAE, it's around 68%, in Oman around 59%. So it's quite obvious that diabetes is one of the leading causes of end-stage kidney disease. And if we look worldwide, by 2030, we would expect around 5.4 million people were projected to need renal replacement therapy by 2030. So for that impact of diabetes on the kidney, we met as 14 UAE nephrology and endocrinology experts from all 7 Emirates. We started to do a consensus based on a modified mini-Delphi process, adapting the American Diabetes Association, the KDOGI, the NICE, and the UAE cardiometabolic guidance. And we had 2 anonymous voting on to agree on the consensus. And the upcoming slides basically are going to tell you exactly the details of this consensus. So the consensus has looked at the first paper at who to screen and how to screen, and the key risk factors for diabetic kidney disease, and the recommendations for managing modifiable risk factors in patients with diabetic kidney disease. And the first question was how and when to screen was answered in this slide. And it says that patients with type 1 diabetes are to be screened 5 years after the diagnosis, while patients with type 2 diabetes has to be screened for diabetic kidney disease at diagnosis and then annually. A more frequent screening is required for high-risk individuals with additional risk factors like those with an existing cardiovascular disease, with hypertension, with obesity. How to screen is by doing both urine albumin creatinine ratio as well as eGFR. But we have added one extra point. If you had a patient with a positive urinary albumin creatinine ratio or a drop in eGFR, we basically have to do a urine routine to look for urine cast or any abnormality that might suggest a non-diabetic form of chronic kidney disease. So the second question that the guidelines has answered is when to refer to nephrology. And the referral to nephrology is essential because early detection might delay the progression of chronic kidney disease. And the question is who to refer. We have divided the criteria for referral based on either eGFR, whether on albuminuria and urine tests, or due to electrolyte abnormalities, or due to any other causes other than a change in eGFR and albuminuria. So if the eGFR is less than 45, patient has to be referred to a diabetologist or a nephrologist. If it sustains more than 20% drop or more than 30% on starting whether RAS blockers or SGLT2 inhibitors, patients has to be referred to nephrology for a review. If there is a significant albuminuria, more than 300 not responding to treatment, or more than 1,000, or presence of urinary red cell casts, this is again an indication for a referral to a nephrology to exclude glomerulonephritis or any other form of native kidney disease. If patients had persistent potassium abnormalities, they might need to be seen by nephrologists as well. Now, patients with refractory hypertension, more than 4 drugs, patients with persistent acidosis, anemia, mineral bone disorder, malnutrition, or a contrast-induced nephropathy, while they're diabetic, they need to be also reviewed and seen by nephrologists. So these are basically the criteria for referral to nephrologists. So the second part of the first paper was basically focusing on management of stage 1 to stage 4 diabetic kidney disease. And the focus was on pharmacotherapy, where we thought that given the evidence, as mentioned earlier by my colleagues, for the SGLT2 inhibitors, for the GLP-1, for the RAS blockers, for the non-steroidal mineralocorticoids, this has to be the cornerstone for management of diabetic kidney disease. And these are basically the 4 pillars for management of diabetic kidney disease. If we look at SGLT2, SGLT2 now is the standard treatment for patients with CKD, whether they have diabetes or not. And they should be started in all patients with an eGFR above 20, and they should be continued until dialysis. So we discontinue SGLT2 inhibitors only at the time of dialysis. We need to make sure that to monitor that when we start SGLT2 inhibitors, there is an expected drop in eGFR that is due to hemodynamic changes, and that does not indicate stopping the SGLT2 inhibitors. And we need to hold the SGLT2 inhibitors during hospitalization and if there is recurrent UTI. A single episode of UTI is acceptable. You need to stop SGLT2 inhibitors, treat your patient, and then reintroduce the SGLT2 inhibitors later. If the recurrent urinary tract infection, if the urinary tract infection is recurrent, then only then we need to stop the SGLT2 inhibitors. The second pillar for management is the GLP-1. And GLP-1 can be started at any stage, but we should be quite cautious when it is when the eGFR is below 15. We can continue. There are many data on GLP-1 on patients on dialysis, and it has shown to be effective, reduce the need for insulin, as well as cardioprotective. The baseline for whether GLP-1 or SGLT2 inhibitors in any diabetic patient with nephropathy is the RAS blockers, which is the standard, and it has to be started in all patients. The fourth pillar is the non-steroidal mineralocorticoid, finerenone. It has to be started on all patients with diabetic kidney disease and albuminuria. If the eGFR is more than 25, we tend to stop non-steroidal mineralocorticoids when the eGFR is below 15. So we don't continue below an eGFR of 15. We need to monitor potassium level when we start non-steroidal mineralocorticoids, and we need to start with a smaller dose and then up titrate the dose. There is some evidence currently that a combination of SGLT2 and non-steroidal mineralocorticoids based on confidence trial, a combination therapy might be very effective, and it produces more than 52% reduction in albuminuria. So these are basically the pillars for management. But the management of diabetic kidney disease goes beyond that, and it goes after you start these medications, then you monitor as well the glycemic control. If you did not achieve A1C, then you can start any of the other oral agents like metformin, insulin, DPP-4 inhibitors. If the patient is not already on GLP-1, we can start sulfonylureas or TZDs or alpha-glucosidase inhibitors to bring the A1C down to target for that specific patient. Again, multifactorial intervention in patients with diabetic kidney disease is very essential, where we need to start statin. We might need to manage the blood pressure using other medications other than RAS blockers like calcium blockers, beta blockers, or any other medication. So these basically are the pillars for management of diabetic kidney disease, which include RAS blockers, SGLT2, non-steroidal, and GLP-1. And this is the evidence behind each of these medications. So these are the 4 pillars. And this is exactly what I mentioned about the GLP-1. We can initiate and we can continue during dialysis and even after kidney transplant. And this is the RAS blockers and non-steroidal mineralocorticoids. This is the rest of the oral agents that we can use in patients with diabetic kidney disease. All these patients need to be modified. The doses has to be modified based on the EGFR. For example, metformin should be half the dose at EGFR of 45, and we need to stop below 30. Some of the sulfonylureas need to be used cautiously because of the risk of hypoglycemia. Some of the DPP-4 inhibitors need to adjust the dose, while linagliptin, for example, 5 milligram is a fixed dose in patients with renal impairment. The multifactorial intervention with the statins, plus or minus ezetimibe and PCSK9 inhibitors is also important. So the other part of the guidelines, it was quite comprehensive. We also discussed the obesity management in patients with diabetic kidney disease, and we focused on approved medications in patients with diabetic kidney disease to be used for weight loss, mostly GLP-1, orlistat, and metabolic surgery. SGLT2 inhibitors are effective, but they cause only modest weight loss in this group of patients. Now, the second paper basically focused on managing advanced diabetic kidney disease. This is the consensus for management of in patients, glycemic management in patients with stage 5 diabetic kidney disease. And when patients go to later stages of diabetic kidney disease, there are many opposing factors. The management becomes a bit difficult. Diabetes becomes more brittle, hard to expect, because the reduced EGFR actually lowers insulin secretion and degradation. And the CKD itself is a state of insulin resistance. So you have more insulin and on one hand, and on the other side, you have some element of insulin resistance. So when patients go for dialysis, having dialysis dialyzes the glucose, and that increases the risk of hypoglycemia on the other side. There are differences between peritoneal dialysis and hemodialysis based on the dialysate that we use. Some of the dialysate fluids contains glucose, more glucose than others, and that makes the management a bit more difficult. But the general rule for management in patients with dialysis receiving oral hypoglycemic agents is you look at the A1C. If the A1C is more than 8%, then you consider adding a basal insulin, because a combination therapy probably might result in hypoglycemia with sulfonylureas and others. If the patient is already on oral hypoglycemic agents, if it is between 7.5 and 8%, and we look and ask the patient if they have hypoglycemic episodes. If no, then we can increase the dose or add another medicine with lower risk of hypoglycemia. If they have hypoglycemia, then if the patient is on sulfonylurea, we reduce the dose of sulfonylurea and add another drug with a lower risk of hypoglycemia. On the right side of this, we have actually divided the medications. Green are the ones with very low risk of hypoglycemia. The yellow ones have a higher risk of hypoglycemia. And this is the action of each of these classes. Like sulfonylurea acts mostly on fasting glucose, while postprandial, DPP-4 inhibitors, and glinides act on postprandial. And there are some classes that act on both postprandial as well as fasting glucose. So you look at each, where is your problem exactly when you monitor your patient, and decide whether you need to handle or tackle postprandial or fasting glucose, and you add medications accordingly. Those on dialysis who are basically on insulin, we have come with sort of a proactive algorithm for management of hypoglycemia and diabetes in patients with undergoing dialysis. And we looked at it like that. If usually when you look at patients on dialysis, those patients at the time of dialysis or the day of dialysis, they develop hypoglycemia, and most of them actually skip their doses. And when they skip their dose, they develop hyperglycemia. So the proactive way is, if your patient is on dialysis, you look whether your patient is on pre-mixed insulin or multiple daily injections. If they're on pre-mixed insulin, then and they're doing their dialysis in the morning, then their morning dose of pre-mixed insulin has to be reduced by 50%. If they're on multiple daily injections, then you look at the basal insulin. If they're taking the basal insulin in the morning of the same dialysis in the morning, same in the morning time, then you reduce the basal insulin by 40 to 50%. If they take it the night before, you can reduce it by 30 to 40%. And your focus here is the dialysis event or the dialysis session itself. The bolus on the day of dialysis has to be reduced in the morning by 50%. So this is a proactive way of reducing the risk of hypoglycemia, at the same time teaching your patient not to skip the dose so they don't develop hyperglycemia, and that reduces the fluctuations in blood glucose. So it's a proactive dose adjustment in patients with dialysis. Another part of the guidelines is blood pressure management in patients on dialysis. I'm going very fast on this because it's two comprehensive papers, and I'm going to cover them in 20 to 25 minutes. So this is about choosing the right medicine, about the pre-dialysis hypotension and what to do about it, and what's your target blood pressure in those patients. We also, in these guidelines, focused and we discussed in details the post-transplant diabetes. We looked at extensive evidence for new classes of medications in post-transplant diabetes. And we found that from the data, around 50% of those who receive a kidney transplant develop post-transplant diabetes. And there are many factors actually that influence the development of diabetes in this group of patients, whether factors related to ethnicity, factors related to the donor, factors related to infections related to the graft, and other factors related to the immunosuppressive treatment that they get. So the first thing we do is the first 6 months post-transplant, we focus on just giving insulin, and whatever recommendations is what to do after 6 months. The most important is adjusting immunosuppressive treatment to give the less diabetogenic agents to reduce the risk of diabetes. And then we have to focus on giving cardio and renal protective medications. And this is the algorithm that we came with. Basically, we focused on SGLT2 inhibitors and GLP-1. There is numerous data recently on the use of SGLT2 inhibitors and GLP-1 in post-transplant diabetes. They reduce the mortality. They result in better graft survival. So currently, they're being recommended as part of the first-line therapy before even after the first 6 months of therapy, and then we can consider metformin and we can consider other medications. So this is the algorithm for the post-transplant diabetes. If we have a patient who developed post-transplant diabetes, then if they don't have any risk factor at all, we might consider metformin. But we know those patients who undergo transplant are basically very high risk. So this group of patients, we go for a GLP-1, a combination of GLP-1, SGLT2 or SGLT2, and this should be a first-line therapy, either single or combination therapy, just to reaffirm what Dr. Mirad has just mentioned. And after the first-line therapy, you look at the glycemic targets, and then you see if the patient is not achieving glycemic control, then we go for a second-line therapy. The last part of the guidelines was basically on management of ketoacidosis, diabetic ketoacidosis in patients undergoing hemodialysis. And basically, we focused on the criteria. Those patients on hemodialysis usually are anuric, so a urine ketone might not be helpful at all. We look at beta hydroxybutyrate, might be very helpful. Or is the standard actually in detecting the ketoacidosis. The bicarb and pH are not very helpful because patients who undergoing dialysis are already having acidosis. So how do we detect those people? Those people with DKA during hemodialysis, usually in most of the cases, because they undergo dialysis, it might be a normoglycemic ketoacidosis. This is one. Second, they already have acidosis. And the third is the bicarb is low. So it will be very difficult to know whether they are in ketoacidosis or not. Usually, you need to look at their acidosis. Does it improve with dialysis or not? If you have a patient who undergo dialysis and the acidosis does not improve after dialysis, then you might need to consider another cause of acidosis. And most of the cases, it's ketoacidosis. So beta hydroxybutyrate is very essential for detecting ketoacidosis in this group of people. So this is the algorithm that we came with for management of ketoacidosis. It's a combined effort by nephrologist and endocrinologist, where nephrologists, because those patients are usually fluid overloaded, they have to look into the fluid status of those patients. They might need to give just boluses of fluids, not like the usual DKA protocol. Nephrologists as well have to look at the potassium level and decide whether at times we need to give potassium or not. While as an endocrinologist, my role is to make sure that I'm giving a dose of insulin. Usually the dose of insulin is half to 3/4 a dose that we give for a usual patient because of the risk of hypoglycemia. So this is the algorithm. Those patients, they need to be monitored continuously during the DKA management. The last part of the guideline, and this is my almost last slide, is the integrating the technology in management of diabetic kidney disease. And we know that management or testing A1C in patients with diabetic kidney disease or end-stage kidney disease might not be quite accurate due to many factors. So SMBG or continuous glucose monitoring might be the answer for those patients. So we need to use the technology in those patients to be able to monitor and guide patients on what to do exactly with regard to their diabetes control. And the last point is the use, as I mentioned, the technology, the insulin pump, the electronic prescribing, and all medications. And the last and most important is the multidisciplinary approach for management of this high-risk group of people, where we have to have the nurses, the primary care physicians, the nephrologists, the diabetes care. We should all work together in providing the proper quality service for this group of patients. And with this slide, I'd like to thank you very much. And the mic is back to you, Professor Juma. Thank you very much.
Many thanks, Dr. Aladdin. Excellent publications. Wonderful talk. Thank you. It's quite dense topic. It's very important clinical topic as well. I would like to thank all the speakers for seeing their time, and we'll be finishing by 10 p.m. as scheduled. So we have few questions to go through, and we're going through the question one by one. Question number 1. Does the oral weight loss medication Foundayo preserve muscle better than injectable like Mounjaro or others? What do you think? Dr. But the floor is open to everybody, but what about Dr. Khadija?
Right. So thank you for the question. We didn't discuss much on obesity today as a subject. We really touched upon obesity as, management as being one of the strategies for managing type 2 diabetes. However, since they've brought it up about muscle loss, one has to remember that muscle loss happens with any kind of weight loss therapy, not just with medications. So even simple sort of lifestyle, diet and lifestyle measures will result in muscle loss if the person is not engaged with muscle strengthening exercises. The same happens with bariatric surgery, and therefore, of course, we've seen with the medications as well. So I think the rather than saying would these agents preserve muscle loss, the things that preserve muscle loss is really a good nutrition and muscle strengthening exercises.
Yeah, thank you so much. Thank you. Right. The next question is for Dr. Aladdin. Which oral medicine is safe for a GFR less than 15?
Well, below the eGFR less than 15, we can use still sulfonylureas at a very small dose. DPP-4 inhibitors are very safe. They don't cause hypoglycemia. SGLT2 inhibitors below 15, if you started early above 20, you can carry on with it until dialysis. GLP-1 are safe as well as insulin. The shorter acting form of insulin secretagogues like repaglinide in combination with insulin at a very small dose might be safe, but you need again to look at the risk of hypoglycemia. So glinides, sulfonylureas, insulin might have a higher risk of hypoglycemia compared to other medications.
Okay, thank you so much. And probably this question for Dr. Mohammed Hassanin. If a patient with A1C just between 6.7 to 7%, so almost controlled, still combination therapy is advisable, especially if the patient's BMI is high?
Certainly, as I mentioned in the presentation, and I think both of us, myself and Khadija, used the same slide of the HbA1c target. So I need to decide on the target, and nowadays we aim for a target for healthy people to below 6.5 or even lower. So I would think of the type of therapy. I will look into what is the person already on, and then if I can combine it in a single pill, it makes life easier. But if not, then I can add on whether injectable or oral therapy that would complement to achieve the targets of glycemia as well as the targets of weight that I want to achieve here.
Okay, thank you. That's clear. And this question is, do you give aspirin without PPI? Usually, routinely, we don't give PPI with aspirin unless there is indication or strong suspicion of risk of GI bleeding. So if the patient has previous history of peptic ulcer disease, chronic dyspepsia, or we give the aspirin along with the high dose of non-pharmacological medications or other anticoagulants, we may consider aspirin. I mean, PPI plus aspirin together, but routinely not. And usually we go for the enteric-coated aspirin better to avoid gastric irritation. Any further comment on that you would like to say?
I mentioned the aspirin in my first case, because the person is very high risk. So aspirin would be indicated unless the person has a contraindication. But the guidelines do not state that we should add on PPI regardless of the gastric symptoms of the person.
Right. And this question, the one who written the question, he wants Dr. Mohammed Hassan to answer it. I think psychosocial history is an adding benefit that affect patients' management to tailor treatment with patients' agreement.
Absolutely. This is an area that we often miss. The psychological impact of the chronic disease, the stress that can put on people, the level of depression. Guidelines recommend having the survey for the mental status of people, and of course the social aspect as well. So that we can, the precision medicine that we talk about is something that we look into all the aspects of the person's life rather than just the HbA1c and the EGFR or something like this.
Thank you. And this question to Dr. Alauddin. How about you measuring a potassium level if you're starting Ferinon? Is it routinely done? How often do you do it?
On prescribing Finerenone, we need to look at two factors. Number one, as I mentioned, the EGFR, it has to be more than 25. And the second, we look at the potassium level. If the potassium level is between 4.8 to 5, then we start with 10 milligram and not 20 milligram. If the EGFR is more than 60, potassium less than 4.8, we can start immediately 20 milligrams. So this is the first thing. So we look at EGFR, we look at potassium. Once we started, we need to monitor potassium around 2 weeks after starting the treatment. If the potassium is increasing above 5.2, then we don't stop Finerenone, we add a potassium chelating agent. Probably we add Lokelma to reduce the potassium level.
Thank you. That's clear. A patient with ESRD on dialysis, and the patient is going to have a hemodialysis session, but prior to that, there's unrecordable hyperglycemia. I think it meant that a patient who coming for dialysis and his sugar is very high. What are you going to do?
We need to look at exactly the blood glucose. Unrecordable means they use the glucometer. We need to check the test. We need to check whether the patient has positive beta hydroxybutyrate, because it might be ketoacidosis as well. And then based on these two factors, we manage. We can give insulin doses to reduce the hyperglycemia. We can start dialysis because dialysis itself is going to reduce the blood glucose level, and we need to monitor the blood glucose frequently in those patients. Here, there might be two different factors. They might have ketoacidosis, and we manage ketoacidosis separately. It might just be a hyperglycemia that needs to be managed. And more important than these two, an unrecordable high blood glucose might be an HHS, which might be precipitated by a myocardial infarction in this high-risk group. So we need to do an ECG. We need to check as well their cardiac status, make sure that they don't have any other whether infection or cardiac event.
And quite challenging cases like this as well.
Yeah.
Dr. Mohammed Hassan, you already alluded to the use of GLP-1 in combination with DPP-4 inhibitor. We see it quite frequent as unintentional mistake in clinical practice, combining the two. Could you comment on that?
Well, they're not indicated. There is no indication to have two drugs of the same class. Occasionally, people on full dose of DPP-4 inhibitors, when clinicians want to replace a GLP-1 and they're not sure whether the person would tolerate it or not, they start with a small dose and then they stop. But that's not recommended as a practice. It's a frequent mistake, and there is no need because it can increase the risk of pancreatitis. Maybe Dr. Milad would be kind enough to elaborate on this point.
I totally agree. I think it's unnecessary utilization of two expensive groups of medications. And as you correctly said, it increases the risk of GI side effects and probably pancreatitis as well.
Yeah. And in the same theme, this question here, can we use Foundayo and GLP-1 together? No.
The concept would be the same. There was absolutely no
yeah.
benefit of having the two of them together.
That's a big bite
One
you
or
can't
the
swallow.
other. Yeah.
And it puts the physician at risk of malpractice because it can potentially have side effects that could be serious without, there is no evidence of it will be any added benefit.
Okay. The number of questions now, they are increasing rapidly. Something happening. They are stimulated to write more and more questions, which is good. But we don't have that much time. We're going to cover a few of them. Right. Is it the A1C at the time of diagnosis? Doctor, do you prefer special range of A1C level prior to the? I didn't understand this question.
It does look like it's incomplete. It's probably just a comment, maybe.
Yeah. Okay. Perhaps slightly higher up. Can we rely on the A1C in dialysis patients and any role of CGM?
Yeah, I actually mentioned that in my presentation. In patients with chronic kidney disease, especially advanced stages of diabetic kidney disease, it becomes very unreliable, basically because of many factors: the anemia, the erythropoietin, the use, when they do, for example, when they go for dialysis, the dialysis itself might affect the hemoglobin level, the hemolysis that occurs during dialysis. So it becomes very not very informative. However, we still use it to give us an idea about the glycemic control. But in such patients, it's very essential. It's very essential to use the self-monitoring of blood glucose. Patients with late stages of diabetic kidney disease should always come to the clinic with their diary, monitoring their fasting postprandial glucose levels. And now recently, alhamdulillah, we have the Freestyle Libre sensor. We use it to monitor their glucose excursions. And it's very important as well if we have a CGM, a continuous glucose monitor, it gives you even a better idea about their glycemic control. So the short answer, it's not very informative. However, we still use it as a guide for management.
Thank you so much. Probably this question to Dr. Mohammed Milad. What is the lowest cost combination available for patients with uncontrolled diabetes and they don't have any insurance coverage?
Difficult to answer. It depends on the economy, health economy that you're practicing in, especially with the availability of generic formulations. Many drugs, many GLP-1 receptor agonists are becoming available as generic, much more cheaper than the branded formulations. So one tends to say combination of sulfonylurea and metformin, but I don't think that holds anymore because many of SGLT2 inhibitors are available as generic and they're quite cheap. GLP-1 receptor agonists, liraglutide and semaglutide have become available generic in some certain health economies. So it depends where you're practicing. So you have to have a shared decision with the patient and look at what's available and what covered for the patient. Thank you.
And some of the insurance, they have something like only 1,500 dirhams per year for coverage of medication. And that's quite a limit, especially with low income population, major limit. Right. Again to Aladdin, I think you have more questions than anybody else. Which patient qualify for CGM on dialysis?
I believe almost all of them, they qualify for a CGM. Especially now it becomes even more important if they are on insulin, whether basal insulin or multiple daily injections. But to monitor their blood glucose, it's essential to be on a continuous glucose monitor. Those on oral agents only, I have a couple of patients who are only on linagliptin, for example, or just on SGLT2 inhibitors, and they're carrying on those patients. Definitely, they don't require a CGM. But any patient on insulin will definitely require CGM.
Yeah. I think this will be the last questions answered already, and we're coming to the end according to the time. We'd like to stick to our time. Thank you so much. And before we finish, could each speaker say just a statement to the health provider attending this module, one single message from each speaker to be delivered to the audience. Start with Dr. Aladdin.
Just a reminder that diabetic kidney disease is highly prevalent. PHC physicians do see around 65% of the cases before they arrive to tertiary care. So screening is essential. Keep an eye on your patients.
Thank you so much. And Dr. Mohammed Milad?
Yeah, I've shown you clinical inertia is still rampant, and I think one needs to agree with patients' targets early and manage patients early and escalate when needed. Thank you.
Thank you so much. And Dr. Khadija?
I
Last
think
message.
right. So we have a lot of therapies in the toolbox, and we need to be able to manage our patients, and not just by reducing glycemia, that is of course important, but making sure that we also manage their cardiometabolic risk. So we're no longer glucocentric, but we need to be focusing on all the other cardiometabolic issues as well.
Okay. And Dr. Mohammed Hassanin?
Structured approach. We have beautiful guidelines. If we follow it and apply a structured approach, we'll get all the answers.
Okay. Thank you so much. Thank you. And with this, we come to the end. And please, a reminder, next week we have another session. It is Module 5, Injectable Therapies, Beyond the Fear. And just another reminder as well, this kind of modules, they are available on the YouTube channel of the EDIS. Please log in if you missed anything. And don't forget to have the questions being answered before and after the modules. The next slide. Okay. This is the QR code. You could scan it now to answer the question, or even if you go to the YouTube channel, it's available there. You could scan it, answer the questions, and the MCQs are easy, educational, informative. And we'd like to thank you for your participation. And I would like to thank all the speakers for delivering wonderful talk and sticking to the time. And it was really fruitful module. We learned a lot. And thanks so much for Lily for sponsoring this summer school of diabetes. And please follow up for the coming events. And we are working very hard to keep the EDIS activity around the whole year, from one module to another, courses, conferences, meetings, and so on. Thank you so much for being with us. And it has been a pleasant number of audience, great number from the beginning until the last minute. Thank you so much.
Thank you.
Bye-bye.
Thank you. Have a good night.
Thank you. Have a great night.
Assalamu.
Assalamu.